So welcome everyone to our psycho-oncology sustainable practice webinar. I think that we are waiting on quite a few more people to come in through the lobby. So please bear with me. Perhaps if you want to get yourself a refreshment, a drink of some kind, we're going to be together for a little over an hour. We've got time for some questions and discussion at the end. We'll see how we go time-wise. But what we have planned is 3 fairly short, but I think you'll find them fairly rich presentations around this topic of, the workforce in psycho-oncology, how we can maintain our well-being, but also other aspects of how we balance our lives and make sure that what we're doing in this field is really beneficial to our patients and clients, but also that we don't damage ourselves in that work. Because it is powerful work and it is important work, but it's not always easy work. So that's what we've come together for. I feel like I'm doing like the patter to fill in the gap. You can probably see the lovely Anne Williams on your screen as well. And our third speaker, Maureen Tan, is just having a couple of little techie issues. So we're just seeing if she can join us right now or maybe a little bit later before her turn to speak. So I will just orient you to the Teams webinar setup. You should have a Q&A option. So on your own screens, it'll be either at the top or the bottom. There's a Q&A box. You can put your questions in there. You can also put them in the chat box. Either way, they can be seen. You are all automatically muted and have cameras off because it's webinar style, which means you're not in the recording. So you don't have to worry about what you're doing at home. You can relax, put your feet up, whatever. Have pets, animals, kids, whatever around you as well. That's always nice. This time of day can be hectic in many households, I think. So I will formally begin our webinar by acknowledging the lands that we are streaming from. I'm here in the north of Boorloo on Whadjuk Noongar country, and it is sacred land, and I want to offer my deepest respect to the elders who have been the custodians of this land generation upon generation, to the emerging elders in the community, and to any of you with us today who may be Aboriginal or Torres Strait Islander people. We honour and respect that long-lasting, beautiful culture, and we're grateful to be here together. And in some ways, what we're trying to do in psycho-oncology, I think, is a little bit of maybe decolonisation. We're looking to shift the health system models and make it a healthier, more beneficial place to be for everybody, for all people. So without much further ado, I'm going to introduce you to Anne and hand over to her. So I'd like to welcome Emeritus Professor Anne Williams. She is an Emerita Professor for the School of Nursing at Murdoch University, and she has a vast track record. If you've been working in this field for a while, you will have also come across Anne's work, I'm sure. She's an acknowledged and accomplished researcher looking at healthcare issues within Western Australia, with a particular interest in staff and patient wellbeing. Anne's currently the acting nurse educator for the Cancer Network as well, and it's through the Cancer Network Psycho-Oncology Collaborative that we have come together today. So over to you, Anne.
Thank you very much, Chandrika. Can I just check that you can hear me and you can see my slides?
Yes, got you.
Yeah, great. Otherwise, it's a very strange feeling sitting here not being able to see anything except my slides. I feel like I'm sitting here by myself, but I'm absolutely delighted to be here this evening to talk to you all about the Fiona Stanley Hospital Cancer Centre Staff Wellbeing Project, which we conducted a few years ago, but obviously the topic is still very, very important. And we've got a long way to go, I think, in terms of staff wellbeing. So I'm hoping today that you'll listen to what I have to say and reflect on it. And I'd really like a little bit of a chat about it at the end. So any thoughts that come to mind, if you can keep them to the last slide or to the question and answer session that we're going to have at the end, I'd really like to hear your thoughts on this. So let's get going. I've been researching and teaching in the area of staff Wellbeing for actually over 10 years now. And this project commenced in 2020 and really was intended to be the first step in a research project towards implementing strategies to improve and manage the staff wellbeing in the Cancer Centre at Fiona Stanley. But unfortunately, there was a change in my personal work circumstances in 2021. So this first step actually turned into the only step that I was able to lead. And that's probably one of the reasons why I'd like to have a little bit of a chat at the end. I don't know if there's anybody here from the Cancer Centre, but it would be very interesting to just talk about what we found there a couple of years ago, 3 years ago now, isn't it? Now, I know we've had a lovely acknowledgement to country there, Chandrika, but I also would like to acknowledge country, but particularly I'd like you to see this beautiful artwork, which was designed by Deborah Jacobs, who's our Aboriginal Cancer Nurse Coordinator, and it represents the Cancer Network WA. And it certainly is a beautiful country that we live in. And yeah, there we go. So the project itself, we were quite a big project team. And throughout my career, I've recognised how important it is when you're doing health research to have a collaborative research team that involves both academics and clinical persons. And this is exactly the sort of team that we had for this project. And just about everybody's on that team in that picture, beautiful picture there taken in 2020, apart from Celine Fournier and Romany Jeans. But it was lovely to be able to get that photo of the whole team. We were also very fortunate on our team to have Professor Jill Mabon with us, who some of you may know Jill's work. She's from the UK and she's one of the top researchers there in terms of staff wellbeing, and led the work that was carried out on the Schwartz rounds across the United Kingdom. But Jill was a visiting fellow with us at Murdoch University for 3 years, and as I said, we were very lucky to have her as part of this team. The other acknowledgement I'd like to make is to the Cancer Nurse Society of Australia, who provided the funding for this project, and also to Susanna Corella, who was acting nurse unit manager at the time and was really fantastic in supporting the project. So most of you will know that Fiona Stanley opened in 2014, and it wasn't long after that excessive staff stress was noted in the cancer centre there, and the senior nurses really wanted to do something to improve the situation, and that's how this project came about. We had some discussions, and they were really quite adamant that the approach to the project should be multidisciplinary. Although it was nurse-led, it was multidisciplinary going forward. So we used an action research design with mixed methods. And action research is conducted in 5 phases, but we were only able to do the first and second phase of the project, and this is what I'm presenting to you today. So that's the planning and the preparing, which is all the parts that you do before you have an intervention. So there was no evaluation in this, it was all baseline information that we collected. So we did a baseline survey quantitatively of perceived staff stress, burnout and subjective wellbeing and coping styles. And we collected qualitative data about the current challenges faced by staff in this area using focus groups and one-on-one interviews. And at the end of the project, we brought all that information together and established a staff wellbeing steering committee to develop a wellbeing support program ready for implementation. So firstly, let's talk about the quantitative results and the baseline survey. Just to say, this was conducted in the first part of 2020. So COVID was just appearing in the world, but not really impacting too much in Western Australia. And it certainly would have been interesting to conduct this a year later and see how people were going. But people were pretty stressed before COVID started, so I can only assume that things got a lot worse following the results that we had in this survey. We had a fantastic response rate of 50%, which was really, really good. And the survey that we used had 4 reliable and valid research instruments, and 3 of them we'd used in previous projects that we conducted. We had hard copies of questionnaires distributed to people, and boxes in their tea room areas where they could fill in and put their completed questionnaires, or if they preferred, they were given stamped addressed envelopes, and some of them posted back their responses, but we were very happy with 50% response rate. Most of the participants were women. Ages range from early 20s to mid 60s. All disciplines who worked in the cancer centre were represented, but the majority were nurses. And 72% of participants indicated that they already used wellbeing strategies, exercise being most used strategy, followed by meditation and yoga. So the first research instrument we used was the perceived stress scale, which has been used all around the world in lots of different settings. It's well known. There's 10 questions in this questionnaire, and they reflect on things that have happened over the past month. So the score is out of 40, with a higher score indicating higher stress. And in this sample, the score was 16.56, which indicates a moderate level of stress. We also used the Oldenburg Burnout Inventory. Now this measures exhaustion and disengagement, and there are 16 statements. And for this, we found, again, moderate burnout. But it was interesting to note that a quarter of the participants demonstrated high levels of disengagement and exhaustion. Next instrument we used measured happiness. And we used the Pemberton Happiness Index, which measured remembered and experienced well-being, with higher scores indicating higher happiness. And again, we had moderate levels of happiness in this sample. And the last we used was to measure coping, and we used the problem-focused style of coping scale. And in this scale, reflective indicates a positive problem-focused coping. And it was really interesting to see in this sample that that was the method that most of them were using. So they were actually coping overall in a very positive way. Qualitative results, excuse me, I'm just going to check my time. Okay, we're all on track. The qualitative part of it, we had 14 participants. We managed to run 2 focus groups and finished it off with 2 one-on-one interviews. By that time, lockdowns had happened and we were into Teams interviews, but we still managed to get the focus groups done before any lockdowns happened, so that was great. In the qualitative findings, we identified 4 main categories and several subcategories, which hopefully you can see there, but I'm going to go through the 4 main categories so you can get a feel for the sort of things that were coming through there. Firstly, stress in the cancer centre. Well, it definitely came through that they were feeling stressed in the cancer centre. There was a lot of negative emotions, frustration, guilt and discomfort working there. And the staff talked about it, how it affected their personal mood and their tolerance for things that were happening around them at work and at home. You can see a quote there: "The levels of stress on the floor can be unbearable at times." One of the things that came through in this section was that some staff felt that care was compromised because of the stress of working in the cancer centre, and that made it even more stressful to work there. They were feeling that, and you can see the quote there, "I feel it's also the stress of knowing that you do a good job, but actually you can't do the best job for those patients. So you're doing an okay job, like you know you can do better." So that added to their stress as well. The next category was workplace challenges. And within this, the nature and complexity of cancer care came through very, very strongly. And they talked about how patients who are being diagnosed with cancer, a lot of them have already got medical or psychological conditions that they're dealing with. So that just made the situation more and more complex. And you'd not be surprised to see that staff felt there was a lack of time to care for patients, that there wasn't enough staff. With the sophisticated treatments that patients were having for their care and the infinite number of patients that were coming through. And there's the quote there: "It always feels very busy, and it always feels like there's never enough time to finish or to see things through as well as you'd like to." Third category was all about the cancer care centre team. And what came through here was a perception of a really positive culture within and across disciplines working in the cancer centre. Lovely quote there: "Well, it's a beautiful team. The team is spectacular, and the commitment." And it really was quite obvious through the data that the team was strong and working well together. But there was obvious differences doing a multidisciplinary project between disciplines in terms of how much control they had over their work environment. And notably, nurses had a lot less control over their work environment than other healthcare disciplines. In terms of coping strategies, this was the fourth category that we identified. Lots of different coping strategies were described. I think I've already mentioned, in terms of self-sustaining, exercise was something that people talked about a lot as helping them to cope with the stress that they're experiencing through work. Other things they talked about: cognitive awareness. So you've got a lovely quote there. So not reacting, remaining calm and coming from a place of empathy. Hopefully you're trying to understand, and so remaining calm, holding your ground, not biting essentially. And you've got prioritizing, with a quote there: "I prioritize." So what actually needs to be done exactly right now? What can wait 10 minutes and what can wait half an hour? What's the most emergent thing right now? What can I do with that? And then the next one, and the next one, and the next one, and then eventually I get to go home. Work breaks were quite interesting. There was a perception that obviously there is a perception, and it is very important that people take work breaks, but some people actually said they cope better by not taking work breaks. That helped them to cope with the intensity of the work, to actually work through their work breaks. Then we had debriefing, and there were discipline differences in terms of debriefing, but still an important thing, but done differently within different disciplines. And innovation. There was lots of innovation happening in the cancer centre, and I think the previous category about the team, this came through quite strongly. Just to give you an example of one of the things that was happening there in the nursing team, They would have regular huddles, and I'm sure you've heard the term huddles, where they come together during a shift, often to talk about quality and safety issues. But in the cancer centre, one of the huddles they did regularly on a Friday was a dancing huddle. And nurses could choose the tunes for the music, and they'd all have a little dance on a Friday as part of their coping strategies. But there were other things as well that they mentioned. But I thought that one was quite interesting to hear about. So, just in summary, this was a research project which took the first steps towards developing a wellbeing support program for multidisciplinary staff in the cancer centre. There were moderate stress and burnout levels, and stress was a constant challenge. But the strengths within the cancer centre team seemed to moderate the stress that was experienced. And there was lots of innovation happening and positive coping strategies. At the end of the project, we established a staff wellbeing steering committee. I was fortunate enough to go to the first meeting where I presented the results of this project, where the committee considered what could be done in terms of an intervention going forward. Unfortunately, by that time, COVID was getting worse and worse, and restrictions were happening. And it's my understanding that that committee only met a couple more times after that, and less people came. And I don't think it's continued. Unless there's anyone here from the Cancer Centre, you might be able to let me know that, which I felt was a shame, because it seemed very promising at the first meeting. All sorts of ideas were discussed. And I think the fact that it was a multidisciplinary team of champions who were going to lead wellbeing strategies in that area, I think there could have been a lot of success and support offered through it. There have been, over the past few years, sort of institutional wellbeing programs set up, which have got various elements to them. But I think whatever the institutional programs are, there still needs to be something at the local level to be sure that you're really meeting the needs of the people working there. So I suppose the recommendation there was that somebody down the track would evaluate what happened with the establishment of the Wellbeing Committee and evaluate that. But I wasn't able to do that. Yeah, so that's what I was hoping to have some thoughts on from everyone that's listening. If anybody got any thoughts about what we do about well-being, because it's such a big issue now. It's a bigger issue, I think, since COVID-19 spread around the world, and particularly through healthcare institutions. And I don't know what the answer is in terms of going forward. So I would be really interested to hear what your thoughts are. So we will leave it there. There's a whole pile of references there of the instruments that we use. There is a report from this project that I have. If anybody does want to read the report, just contact me and I'll send you the PDF. Back to you, Chandrika.
Thank you so much, Anne. That's fantastic. And I really I want to honour your call out for people to give some feedback, but also to remind you that they can't talk to us out loud because the webinar is being recorded. But people listening, you definitely can put your comments or your questions in either the chat box or the Q&A box. I did a little test in the Q&A box while Anne was presenting, so it does work and it can be seen. So we will come back to those at the end. I'm now going to see if I can share my screen and do something very weird, which is to introduce myself. I possibly should have asked someone else to introduce me, but there you go. So if we have not met before, my name is Chandrika Gibson. I completed a PhD, or at least over a year ago now. So I'm kind of a baby researcher, but I'm not new to this field. I've been working in supportive care and integrative oncology support services for about 20 years. Mostly I've come to that via my background as a yoga teacher and a yoga therapist. So actually the staff wellbeing aspect is pretty close to my heart. I've done quite a bit of corporate wellness work, including teaching yoga in various corporate settings. But then, I went into more research focused areas. And so some of what I want to share with you today is based on my PhD research, but it's also kind of an accumulation of observations and ideas from being in this space. And it's also a call to action. Anne has raised a really good point. This thing that bugs me the most, perhaps, is when things that are really powerful for helping us manage our own stress. For me personally, I'm very close to the world of yoga and meditation. When those things get co opted into improving the profit bottom line rather than the people well-being, I find that problematic. So this idea that each of us should be practicing self-care is obviously pretty prevalent when it comes to sustainability in the workforce, but there's a lot more to it systemically. So this is my call, really, a case for trauma-informed workplaces. I would like to acknowledge my affiliations. I sometimes don't know which branding to put on which slides, but I work for Breast Cancer Care WA. My role is project coordination, and I'm involved in research and evaluation and program development there. So some of the preparation for today has been done on breast cancer care time and with support from the team there, which is wonderful. I'm also an adjunct to Curtin University, and the other two logos there are my small businesses. Surya Health is a private practice, which is a yoga and counselling holistic wellness centre with a special focus on people with cancer and other life-limiting illnesses. And then Wisdom Yoga Institute is a training organisation for yoga teachers who want to work more with people with chronic health conditions particularly, but many of our trainees have also gone on to run workplace programs. So I want to start with the big picture of trauma. Trauma means wound. And, in modern health, we still are doing that Cartesian split too much, where we think that a wound must be in the body and that something that is mental or non-tangible, non-physical is harder to measure. But actually, trauma is trauma, whether that is an open wound or whether that is an injury to the psyche. The person has had an injury that's characterized by multidimensional aspects. And so trauma, whether it's for our clients or patients, or whether it's for ourselves, or whether it's systemic, is a biopsychosocial and also, I believe, a spiritual issue in some circumstances. What defines trauma is any event that poses a threat. So it doesn't have to be actual, it just poses a threat of serious injury or death to oneself or others. So if you're working in psycho-oncology, supporting people with a potentially life-limiting illness, already you are exposed to the threat of serious injury or death. And it elicits feelings that are strong, that are big, that are fear and helplessness, or perhaps horror or revulsion. There's a number of different types of trauma. You're probably familiar with a lot of them. Acute trauma from, a single event, falling off your bike or your skateboard. Complex trauma where perhaps there are multiple things going on. This is common for children growing up in domestic violence situations, for example. There may be complex aspects to their trauma. Developmental trauma happening during childhood and adolescence. Sorry, I'm being admin as well. We opened with an acknowledgement of country, which really holds this understanding of the intergenerational trauma that we know has occurred to Indigenous people around the world, but it's also in everybody's intergenerational story. We carry in our DNA the history of our ancestors. And then what we're really focusing on this afternoon, the vicarious trauma, which is considered a secondary trauma. It's not actually happening to you necessarily, and yet your nervous system interprets it and holds it just as if it was. And any of these types of trauma can have lasting effects that are categorized as post-traumatic stress disorder. The good news is most people recover. So there's a sort of natural healing process after a traumatic experience where most people can find their baseline and are resilient. They bounce back, not necessarily bounce forward, but bounce back. And that's about 3/4 of people. However, for a reasonable number of people, there are lasting effects. And so, this picture of post traumatic stress can have all kinds of manifestations in a person's life. But typically, there's this hypervigilance and hypersensitivity, and that's both mental and physical. So the person feels defended and defensive. They may respond with aggression. They may choose coping mechanisms that help them feel less, but may be detrimental long term, or they can go into shutdown mode or avoidance. There's all kinds of ways that people try to metabolize their experience or not. According to the DSM-5, which, we might pose some, skepticism around some of these categories and criterias because people are not textbooks. However, I think this is of interest in terms of us as health professionals or people working in supportive care roles, but also for people going through cancer. This is the criteria that means that someone would be classified as having post-traumatic stress disorder. So they had an exposure to some kind of threat. They're having intrusive symptoms, so they can't stop thinking about it, or they're waking up with nightmares, or they're getting triggered by things in their environment where they have that physiological stress reaction. They're doing things to get away from or avoid the stimuli that bring up those strong feelings. And they're having quite a negative kind of framing about themselves and about the world. They're seeing things through that negative lens. There's hyperreactivity, hypervigilance, poor sleep, a difficulty in winding down. And to classify as PTSD, it's lasting for more than a month and significantly causing distress or impairing functions. And there's no other reason. It's not due to substance use or another medical condition. Trauma impacts on health. So, if we're thinking about cancer, we're thinking about people who are getting diagnosed who may have already had a long and complicated history with many different aspects of trauma. There can be that generational embodiment, those intergenerational traumas that we inherit. There's also the social determinants of our health, which can be a reflection of how we've coped with our trauma, but also are systemic. The places that we live, whether it's easy to go walking in nature, whether we feel safe in our homes, all of that sort of thing. Adverse childhood experiences, if you've ever done that particular questionnaire, if you score, I think it's over 4, then your risk of chronic illness goes up substantially. So adverse childhood experiences are likely to be very common in people presenting for support for their cancer diagnosis. The trauma may not be cancer related, it may stem from something far back in their history. Similarly, those early developmental traumas may disrupt development, and they may have social and emotional and cognitive impairments. And a common way to cope with trauma is to adopt risky health behaviours. Again, when it comes to cancer, examples of that might be people avoiding screening because they may feel re traumatised by screening. This new advent of do it yourself cervical testing is really great for getting around some of those issues, but there can also be health risk behaviours like substance use and diet and exercise that isn't optimal for that person. So you can see that the risk of complicated health situations goes up, and trauma can be the foundation of that. So I think I kind of said this already with my example, but there is this intersection of trauma with cancer that might occur prior to diagnosis and might also extend beyond diagnosis through treatment. And some people might say that, treatment is a series of traumas. There can be medical trauma. There are all of the scans, all of the surveillance, there can be remission or there can be recurrence. And so this intersection can go on through the whole cancer continuum. And hopefully we don't lose too many people who find the cancer experience re-traumatizing. I mean, lose them to care, but also lose them in any sense. So you're working in a role where you support others through their cancer experience. and you want to sustain this role. You want to be able to do it long term, and you want to be able to kind of maximize your impact. And, Anne pointed out that sometimes the pressures of working in this space make people feel like they can't do the best job possible. So we really want to support the workforce in psycho-oncology and prevent burnout. And vicarious trauma is a contributing factor to burnout. The definition of vicarious trauma is it's a negative transformation in the helper that comes about across time from ongoing empathic engagement with trauma survivors and the content that you're working with, combined with their commitment or responsibility to help them. So empathy runs out. We can have empathy fatigue or compassion fatigue. The greater we're exposed to trauma, the greater the risk that we kind of take it into ourselves, that we have this vicarious trauma experience. And it's not just in the oncology health workforce, it's across health and any frontline service providers who are there with people going through trauma. In my PhD, I interviewed a number of health professionals, 21 health professionals of different disciplines, many of them counsellors, psychologists working in psychosocial support, a couple of social workers, as well as medical oncologists, radiation oncologists, surgeons, etc. So I published an article, and you can see the reference there, along with Georgia Halkett, Moira O'Connor, and some clinicians. And I called it Burnout or Fade Away. And I actually think that my Neil Young reference got completely lost. And now I wouldn't do that. I wouldn't title a journal article with a song lyric. But it really seemed to me to represent what was going on amongst these health professionals. They were either acknowledging their own burnout, or they were saying, no, I don't really feel burnt out, but I have gone part-time, or I've changed tumor streams, or I'm moving to do my yoga teacher training came up a couple of times. So people were burning out on the job. They were finding that their own self-care strategies were falling by the wayside, and they were fading away either from disengagement with the work or from trying to manage their work so that they didn't have to be as frontline and be exposed to so much trauma. You can see some quotes there from the health professionals. And I think these do speak to the way that they take on board the things that are happening for their clients, and it influences and impacts their own lives. This person said that they spend so much time with people that they don't know, worrying about them, that they don't really have a whole lot of capacity for the people they do know. Someone else said it outright. I can't do this forever. It's burning me out doing that sort of work. From the medical oncologist, there was a kind of joking, well, we're all going to retire at 50. But that's a terrible loss, right? When we think about the investment in their training and how skillful and how amazing they are, we don't want people to leave the workforce at 50. Obviously, for the individual, that might be a good thing, but collectively, that's a real loss. They also really identified with the people they were working with. For example, this person who talked about understanding the anxiety of the patient, thinking about how young they are. They've got a young family, young children. They want to live to see the next birthday for their kids. That's a lot to take on board. So it's not so much the event, the traumatic event. It's not so much that you're seeing people facing their mortality, that you're seeing people having difficult, rigorous treatment regimes, but it's how it gets organized in your own nervous system that makes things change. We rewire our nervous system all the time based on our experiences. You might have heard the expression, neurons that fire together wire together. And so what that really means is we get better and better. We get more efficient at generating stress, at generating pain, at generating frustration, or whatever our expression of this vicarious trauma might be. What can be really helpful to support the organisation of our own nervous systems is resources. Someone who's empathic. That can be our own wise, kind, nurturing self if we can practice self-compassion, but also it can be someone outside of ourselves who helps us hold and metabolize this experience that can be really fragmenting. So the way that we rewire our nervous system is by repeating the message to it that it's safe. And we can't just tell ourselves, you're in a safe place, it's okay, this isn't happening to you. That doesn't work. Our nervous system isn't literal like that. It needs to be embodied and felt. And I think that probably speaks to why exercise and yoga and meditation, these embodied practices can be really helpful. What's your stress response? Well, most of us have a pretty well practiced go to. These are some of the ways that the nervous system responds to traumatic experiences. So, that fight mode, getting aggressive, maybe in the workplace, we're not openly aggressive, but there can be some nastiness that comes through, some less than benevolent, less than our best selves. The flight response might be why people go part time or, change the way that they're working. Freezing can make it really hard to get things done. It's a really natural response, though. Just hang on for a moment. Keep still and keep safe, and the threat might pass. You might also see in the workplace how some people respond to stress and to trauma with a fawn response. That is, trying to make the scary source of threat your friend, getting closer to it. It can be the way that people operate in terms of hierarchical team structures, but it can also be that people lean in a way that isn't necessarily healthy for them. And what they might find when they get home is that they go into that flop response where they're kind of hypertonic. There's not much going on. They're not responding to their family members or doing other things that are meaningful to them. So, what has been shown to help? How can we intervene in trauma? Well, these are the kind of principles that any useful trauma intervention would have. It has to have that embodied, felt sense of safety, which is a lot easier to say than to do. I'm going to talk about some practical ways soon. We want to calm down regulate the nervous system, come out of that hyper aroused state and come into the window of tolerance. So, not hypo, not flop mode, but back to a kind of place where you can respond from. Connection really helps. Trauma is worse when we feel isolated and alone within it. We need to feel connected. And as Anne referenced, the team that we work within can be that point of connection. We also need to feel that we have autonomy, we have some ability to change things. Again, the structure of teams and workplaces can make some people feel quite disempowered. So, a sense of self efficacy, which naturally brings forth hope that the future might not be quite like the past. So, regulating our nervous system. Well, there's a few simple techniques here, things that we can do for ourselves. I know many of you working in the space probably do these with clients, but I don't know if you do them for yourself as often as you might. I know that I, need to listen to what I tell other people too. So you can use your sense organs. You can use your body to help you recognize that you're in the here and now. Sometimes, those complex trauma things, they unleash a whole bunch of other stuff that isn't happening right now. So if you can feel your feet, and you can do this now while you listen, if you can feel the touch sensation, your feet on the floor, if you have a nice texture on your clothing or your seat, you might touch with your hands. You might look around and notice colors or notice nature. So you can use your senses to help you get out of your head, back into your body, and also to orient to the world around you in a way that feels safe. Grounding is similar. It's using the earth and your body to come back to the present. You can trick your body into a sense of felt safety by doing some deep belly breaths. So when we breathe deeply, most of the information that runs through the vagus nerve, 80% of it goes body to brain. So doing the bodily action, changing the physiology first, changes the mindset. That's what we can do for ourselves individually, but for each other, we can also co-regulate, and a healthy team does this with safe touch, non-sexual touch, nothing creepy, but touch can be really helpful to co-regulate with looking at each other's faces and connecting and smiling, and also having some way of including the natural world, touching animals, they're great for co-regulation. So, for ourselves and for our clients and patients, these simple but powerful skills can be useful because we are actually all one community. And so, the way that we respond to stress, we are like animals in a herd. If we're reactive and freaking out and hyper alert, others around us will also pick up on that and become that way too. So, seeking inner and outer resources that give you a felt sense of safety. That is me on the beach at sunset. embracing that, positivity. Well, they're negative ions, aren't they, from the ocean, but the good vibes that are there. Cultivate I must have edited that, lifestyle. But it would have said dinacharya before, which is the Sanskrit term for a daily lifestyle that heals. You can do any combination of these things based on what resonates with you. So you need to follow your own heart to find what is a healing resource for you. For me, it's definitely nature, but also movement to kind of complete the stress cycle by moving the body is really helpful. That speaks to our kind of ancestral flight aspect, our run away from the danger. If you can move the body, you can discharge some of those stress hormones and rebalance your nervous system. You can use your breath. So diaphragmatic breath is just one component of that. Be a little bit careful with the breath work techniques that are kind of trying to release trauma. Go for the ones that are down regulating for the nervous system. So longer out breaths generally. And then all those other components, seeking social support, but also seeking professional support. And I mean this for you as health professionals to seek your own therapy experiences with trusted others. Because by doing the work on ourselves, we can really move ourselves towards being trauma informed and decolonizing ourselves, which makes it a lot easier then for the system changes to happen. We're moving out of this old school health model where the person providing care was the all knowing expert into a more equanimous, I want to say. That's not the right word, but a more equal relationship where you're on the same level and you empower your clients to be the experts on their own selves. Of course, you may come in with some particular knowledge base and particularly, around treatments and things like that. Yes, you want to share some of that expertise that the client perhaps does not have, but you do it within a relationship where that person feels like they know about themselves. So instead of doing things to people, we're doing things collaboratively with that person. They're a participant in their own care. They're having informed consent. They're making good decisions. And so then instead of our treatments focusing on their symptoms and their pathologies, we're able to step back and observe some of the things that are going on for this person are those trauma related coping mechanisms, and we can support them to work more healthily with them. In a traditional model, you give the person what you have. So if you have a hammer, everything looks like a nail. Whereas trauma-informed care is much more person-centered. It inquires about what that person might need, not giving a standardized protocol necessarily. And that way, instead of thinking that people who opt out are resistant or are non-compliant, we come into a deeper kind of connection where we can try to understand what's going on for them and what they need. Then we're really healing, not just treating. So the principles of trauma sensitive care. So systems and organizations need to be trauma informed. And then when you come down to that one-on-one or clinical kind of relationship, then we're doing trauma sensitive care because we're aware that that person we're working with has a history of trauma. Even if they haven't disclosed anything, it's so ubiquitous, everybody has something. So we try to create environments that feel safe. That's physical environments as well as relational environments. We try to give people choice, not overwhelm them with hundreds of choices, but give them choices they can make that are real choice. Collaborate with them, get them involved in their own care and empower them to manage themselves really well so that all the stuff that's non-medical, they can find support from you, yes, but also broader than that in their own environment, in their own communities. So we're back to our own vicarious trauma. So I've mentioned some things that might help in terms of self-care and self-regulation. Now I want to think more about systemic support. Hmm, The order of my slides is a little bit weird, but that's okay. So effective treatments. I put this one in because I was thinking about supervision or mentoring. So if you work with people in any kind of role, ideally you have someone you can debrief with, that you can share your experiences with, who is a skillful, experienced practitioner. And that's why I included this because common treatment elements for PTSD involve all the things that I feel like we ought to have in our supervision and probably don't. that you can actually lean in. So instead of avoiding, there's a safe holding space for a bit of exposure, confronting those memories, but with support. To modify those traumatic memories, and this can be techniques like EMDR, the eye movement desensitization technique. So some of you might be working with that. An opportunity to move back into those environments. So now when I'm thinking about vicarious trauma and workplaces, I'm thinking about people leaving workplaces because they've had too much trauma, they're burnt out. Finding a way back in could be important, and the right kind of mentor or supervisor can help with that. You can also do some management stuff, like looking at your numbers, looking at your caseload, and being realistic about how many people you can genuinely serve in a one-on-one capacity each week. If you're running groups or classes, consider that as well. Make sure you've left space in your lifestyle for a self-practice of some kind. It doesn't have to be yoga, but something that nurtures you. Seek support for yourself. Get out in nature. Do your best to optimize your nutrition. Feed yourself because you love yourself. Don't try to punish yourself with food, and same with exercise. Practice all your sleep hygiene. Do everything you can to get rest and genuine sleep. And use that professional support that is available, debriefing and mentoring as part of your self-care, but also keep learning. Like this, doing professional development can help kind of feed you and fill your tank. Systemic change is harder, as Anne alluded to, but this is a call for each of us to be a champion of change at every level and in every environment where you have some influence. Because I can imagine an ideal world, and I'm sure you can too. In my envisioning of a health system and psycho-oncological support, we have from the top of every organisation happy, relaxed, compassionate executives and managers, where there's sustainable funding that includes the ability to innovate. So it's not just enough money to keep delivering, but you're scraping by and stressing every financial year or every funding round. There's enough there that you can grow things, and that you're working in well-staffed with enough people, diverse teams with different skill sets and different backgrounds, getting paid enough to live comfortably. Be great, wouldn't it, if that included housing that we could afford, with flexibility about how and where you work, with adequate or ample leave, even better, and professional development all built in. Into a space where there's psychological safety at work, and where that holistic care extends to the patients but also to the staff. And ideally, services are delivered close to home for patients and clients, but also for providers. And that compassion can be enacted in every interaction. And the example I've got there was at the recent COSA conference in Melbourne. I was really moved by the presentation on decarbonising oncology. I expected it to be about, washable scrubs and surgical equipment that could be, sterilised and things like that, not so much throwaway culture, but they also thought about buildings that are ecologically friendly, that don't require fossil fuels to run. And they thought about the food that's served in treatment centres and how that could be greener and healthier and less waste could come into that. So there are systemic ways we can make change, but it requires champions, I think. So to summarise, how do we make our psycho-oncology spaces trauma-informed? Well, it's up to each of us to lead and communicate the importance of being trauma-informed. We want to work with our clients or patients in a way that's collaborative, engaging them in this kind of conversation even. More training for both clinical and non-clinical staff, so it's throughout organisations. Creating physical and safe and emotional, psychologically safe environments, which is about culture building, which is an ongoing process. Preventing as much as we can secondary traumatic stress in our workforce, and building a trauma-informed workforce where people recognise not only the trauma in the people they're working with, but also in their own lives. They have enough capacity to do some healing work for themselves. There can be screening for trauma, there can be specific trainings, and there can be partnerships. These can all be super helpful ways to make spaces that we operate in more trauma-informed. So thank you for listening. It is a little weird, as Anne said, to not be able to see your faces while I'm talking. I hope that that has come through okay. I'm going to stop sharing, but you're welcome to put any comments or questions in the chat or Q&A box. And I'm going to now hand over to Maureen Tan. So let me introduce Maureen. Maureen is a lecturer in counselling at ECU, Edith Cowan University, and she's also an experienced mental health clinician with a special interest in this field, psycho-oncology. She's currently doing her PhD in the psychosocial needs of families going through cancer experiences, and she's going to share with us about the idea of compassion activism as an action research approach in allied health practice. Over to you, Maureen. Can't hear you yet.
Yeah.
That's better.
Okay, great. I might just leave my headphones off. Yeah, hello everyone. My name is Maureen, as Chandrika said, and I suppose I come to this when the invitation was afforded to me with multiple hats. So I'm an educator, I'm interested in phenomenology, and I'm also a clinician. So today's presentation, I think, is really more about exploring with you the idea of practice and what is compassion. I might start off with a little anecdote. I think we've all heard the word compassion a lot. And I remember before compassion, I think gratitude was very 2021. And I remember going to my supervisor and she said, I'm a little bit sick of it. Everyone's so grateful. And that's not to say that, we shouldn't be grateful and we're not grateful. And I think we are. But I think when we get this idea of, well, there's so much compassion around. So I think you're very familiar with Kristen Neff's work and probably heard the idea of self-compassion particularly. And yet we're all, according to, the Anne and Chandrika who was presented to us, this idea of, well, what is self-compassion? And I think particularly for those of us in healthcare, we very much also enact that carer-patient dynamic within families. We tend to put ourselves and our needs last, particularly for those of you who are working at the pointy end of death. Our needs are just not quite as acute. And so there's this kind of slowly chipping away and the dying of our spirits in some ways. So that's a little bit about me. And for now, I'd just like to invite you, whatever you're doing, perhaps you're having a drink or standing somewhere, and I'm going to tell you a little story. But while I do that, I would like to invite you to go and find a pencil and a piece of paper and write down a word that you associate with compassion. So it could be kind, it could be care, it could be love, whatever it may be. It doesn't have to be complicated. So I'm going to get you to think of a word that also expresses your value as a person. So if the two can marry together, that would be great. So a word that expresses your value as a person. Excuse me. So I'm going to start with a story in that I didn't grow up in Australia. So in the summer holidays of what might be considered as an Australian summer, I spent it with my maternal grandmother. So in reflection, she would probably be what most would consider poor, but it never occurred to me as a child that she was. So she lived in this kind of wooden hut that had 2 bedrooms on stilts over a riverbank, and it sounds so idyllic, but it's not. It smells, there's lots of traffic. And this was in a fishing village in Malaysia, and you can hear the kind of whirring of a boat going past, a fishing boat. And there really wasn't very much to do, and definitely I didn't have any kind of sophisticated toys. It was kind of wood blocks and nature that I found in her backyard and in the riverbanks that is now a legitimized curriculum in childcare. So anyway, my favorite thing to do was actually to lie on my belly and sort of place one eye between 2 planks of wood on the ground and watch the fishes and the occasional sea snakes sort of swim around when the tide came in. And I would sort of watch them as a little kid and wondered, wow, what is it like? Is it really hard work to have to swim around all the time and keep moving? And then what I think really bewildered me is, well, what happens to them? Where do they go when the tide goes out? And I just can see the kind of muddy red earth of the soil and of the riverbed. And so I was just thinking, well, why did this story sort of float into my head as I was presenting for this, when I was organizing this presentation? And I realized it was because when I think about myself as a clinician or a teacher about cancer, I think that's what separates us. You know, that there's between me and the fish when I was 5 years old was a horizontal 3 centimeter dimension of wood and nails. But for us, you know, as allied health, it's really life and death. And so we come to, I suppose, the idea of situatedness, what we think is where we are as clinicians. And I think very often we think of, well, who are we? You know, when you think about who you are, you probably think, well, I'm a clinician, I'm an educator, this is what I do, my job involves this, and the value of my time in my work is measured. How is it measured? Is it measured by the amount that you do and the number of patients that you see on your rounds, or the people that you've seen in your care, whether you're allied health? Or is it how you've been with the person or the people that you've seen that day? How have you been with them? And I think this is something that we kind of forget about when we're thinking about people. We tend to kind of measure our worth by how we do, because our time is monetized, right? So time is paid, and my time is money. That's often what we hear as well. So then then we think about situatedness as this sort of, where am I? Who am I? What am I? And how am I being with this person? So straight away, the dualism between our minds and the world that we're in is not so cut and dry. I think there's the way you perceive the world and the knowledge that you accumulate over life is what we call life world, and what Heidegger refers to as a force structure. So broadly meaning we have within our minds a framework of notions based on past experiences, essentially how we make meaning of what is taking place as it is taking place. So if we think about it like that, the way that we perceive and relate to the world as having this sort of background structure in our minds, then it makes sense to think that we have this kind of tension with our environment, our sociopolitical and sociocultural discourses that I think both Anne and Chandrika have touched on as well. And this has a kind of weft and warp on the fabric of our worldview, right? I remember, I'll tell you another anecdote. I remember going through Karrinyup Shopping Centre with a checkout girl, and I always go through the same one because I'm a creature of habit. I think we mostly are, but I am even more so. Anyway, I was talking to the checkout girl, and she said to me, you know, we were told that we would have to hurry up a bit because we're the slowest. We're the slowest in the state in terms of getting people through the checkout. And I said, well, did you tell your manager that you're doing a great job at customer service in their PR, in building relationship with your customers? And so I think that captures well, you know, in terms of what's expected of us in our workplace, in terms of what we do. So my question to you is, who are you really? And this has relation to the word game that we're about to play. And this is what I kind of thought about, that we should probably explore. And I think you are probably all very familiar with Yalom. He is a favorite author of mine. He writes so well. But I think he also, amongst all the existential phenomenologists who are psychotherapists, he puts it most clearly into the 4 existential pillars. And I think in our profession, we come across death anxiety in all its metaphorical iterations, right? It's that, it's chemo, it's getting your blood drawn, it's the feeling of sickness. And what this means is the chemo working, is it not working? the first diagnosis. So when we're in those environments where whether we're listening to someone's experience as a counselor or we're an allied health member in a hospital setting, we can think about it, this kind of creep of helplessness and how we mitigate that with helpfulness. We're so helpful all the time. We want to do. And I love what Anne Lamott says, as a caution, don't get your help all over everybody. Just be with them. Don't think about help all the time. And I think she's right, in that sense that we should think about it, how we're being. So I think one of what Yalom talks about, and just to quickly summarize for those of you who might not be familiar, that it's freedom, meaninglessness, isolation, and death anxiety. So he, I think, sums it very well in one of the quotes that he takes from Nietzsche, and that is, everything fades, opportunities exclude. So I think for those of us who's ever sat down and listened to a story of someone who's unwell, really sick, or at the active dying phase, they're reflecting on their lives. And more often than not, I find in my work, is people talk about relationships, the relationships that they've had, the relationships that they wish they'd had. And so there's I suppose, process of reconciliation in the work that we do. And when we think about the needed openness of how we need to be with a person, and how we're not very equipped to think about that, because our energy and attention is always expended towards doing. So my invitation again for you is to consider what is actually, when we think about compassionate activism, how are you being active? It's an action. So how are you being in the workplace, particularly with yourself as well? So these are, I think, 4 quotes that I found. When we think about stillness, stillness is a presence of being. So when we think about situatedness, and I'll get you to perhaps just take a moment or two to reflect on your own situatedness as a human being. Where are you? What are you doing? What's going on in your life at the moment? That's the kind of stillness, perhaps, in just a minute or two that we can invite, just to reflect who we are. And I love this quote by Thomas Merton, where he says, silence is not the absence of something, but the presence of everything. So in that moment, I think, when we shut out that outside noise and we just get in touch with how we are, we so often turn to distraction just to kind of alleviate some of this existential suffering that we bear witness to of others and our own. So I showed you the recipe for before, and I think we all face it in some way, right? I think it reminds us all, when we're working in psycho-oncology, that is also an end that's coming to us. And so how do we cope with that? How do we, in order to be in touch with that as a truth for ourselves, but also to be able to hold out a hand and to hold another person's hand and travel with them. So I would like to paint a picture in your mind that when someone is walking along the precipice of dying, you are on the other side and they're leaning into you. But it also means that you're looking into that horizon where that's coming, where you're moving towards it as well. So personal and professional is not so separate. So I think that the invitation is for us to actually, maybe if we get in touch with that for ourselves, we can be really much more available. We don't need to do, actually, we just need to be with. And in that stillness, we find it. And, stillness is synonymous with contemplation and awareness of the uncertainties of our own lives. It can be in a job loss, it can be in a divorce, it can be in the loss of a child, it can be in the loss of a family member. It comes in so many iterations that and I think every little iteration is an opportunity for us to think how we want to be with that, to cultivate a little bit more openness by just being still in that moment. So I'll come to the next slide and think about, if we're talking about stillness in a being, how do we find that? How do we work and discover ourselves in that space between two beings in the world, right? And I think, and I thought in my title, I talk about conversation. So how often when you think about conversation, are you truly facing the human condition? Or are we trying to solve problems? And so often it's, you know, I think problem solving is a highly cognitive task, but it's almost mindless in that you're not in that there is no, often it asks you to be cognitively engaged, but it doesn't invite your heart into the space. So when I talk about, and that becomes more of a solution-based discussion. So when we think about our capacity to converse with someone, I think we need to think about how we are being with ourselves. And I think I like Bruce Lee's quote before: stillness is really real when we can be in touch with stillness, emotion. So dialogue is a way of learning to listen deeply when we talk about conversing, and allowing that kind of force structure that I talked about before, the force structure of meaning and perception that we have, to shift, to become flexible, to change. And that in itself, when we're in conversation with someone, becomes illuminating, and we start to learn something when I think we allow that space where a dialogue is an exchange between two people. But then when you think about it, how often a conversation is two monologues. So I tell you something about what happened to me, they tell you something about what happened to them, but there's no real real generativity of new perspective, of new information. And when we talk about relationships as a key feature, the generativity based on a conversation allows us to develop unique perspectives and experiences. And as a result of that, create shared meaning. And that's the richness of being in between, in that space between two people being in the world, right? That suddenly you're not so aware of what's going on around you, but you're deeply aware of being present with another person. Everything fades out and they're right there. And I think often that's what people crave. Whether you're sick or not, that's what we really crave as human beings. That's in our nature. And a conversation is always alive and evolving at the same time. So that when I talk about that sort of connection, we're thinking about, well, how do I connect with myself and how do I connect with other people without thinking about what I'm saying, and just being familiar. What's the feeling of openness when I'm being open within myself to another human being, whether it's your children, your partner, or even with the people that you work with. I think that in itself is a kind of compassion for how you are in that moment. You don't need to do anything more. You just need to be with yourself. And when we can be present with that feeling, we can find that stillness in that intersubjective space where, in that shared meaning and that created mutual understanding, you and I are the same. There's no difference between two people. So yes, my slides. Okay, I'm just sorry. I'm finding the next arrow. So I found some quotes that talks about compassion, and I had a fancy way of doing it where they pop up one at a time, but it's clearly not working. But that's okay. That's all right. So I think these are probably the ones that really touch me in that compassion is a radicalization of our time. In where we're supposed to be doing, the most precious thing, the most precious gift we can give someone is to be with them with the time that we have, because you can't buy time, you have to give it. You can have a job where you're supposed to work 38 hours, but when you're really being in an inner experience with somebody, it's a gift. It can't be taken. So that is a kind of activism. And compassion isn't about solutions, it's about being loving. And I think what I love is compassion is a verb, it's an action. So for those of you who've never heard, I think Bell Hooks, I love what she writes about in her book All About Love. And she says, well, if we stop thinking of love as a noun, but to think of it as a verb, then that should permeate everything that we do. And love and our actions are then congruent. You know, and Chandrika touched on intergenerational trauma before. You know, in my generation, it was okay to smack a child. That's love. How confusing could that be for children, right? I love you, therefore I smack you. Sometimes it can, when, you know, but sometimes really it doesn't work. And so, you know, when we kind of take away that layer of confusion, love as a feeling and love as being and doing should be congruent. And I love what, you know, and this leads on to what Pema Chondran says, that compassion is not a relationship between the healer and the wounded. It is a relationship between equals. So we don't see the patient, we don't see the sick person, we see them. We see who they are, how they're being, how they're feeling in that moment. Beyond the cancer, that is something in their body. We see their spirit. And I think that invites us to find an openness in ourselves and be in touch with our spirit. And spirit can be religiosity. Spirit can also just be your values and your beliefs. So in Christian religion, we have Christ consciousness. In Buddhism, we have Buddha nature. So those are the things that we touch on. So hopefully I'm letting my trick out of the bag that you can see. How do I move my slides? Okay. Ah, look. Yes. So I invite you to kind of think about your word now and just spend a few minutes playing with it. So, for example, if you had kind as your word, can you expand on it? Can you think of a word that starts with K? K is a bit hard, so sorry if you pick kind, but K, you know, think of a word for K and so on and so forth. So let's play a little bit. It's Thursday evening. We're all kind of tired. We've listened a lot. So let's play a word game. And I don't know if Chandrika can unmute everybody so we can have a bit of a party. No, that's a shame. Yeah, but well, anyway, I don't think I kept a very good eye on my time, so just as well. So I think compassion activism for me, and I would like to invite you to think about your practice. What defines your practice? You know, in the word that you've got in front of you, and that's the word that you've chosen, how does it define your practice? And would you like to think about integrating it in a deeper way tomorrow or even right now? So for me, practice is really about being present with yourself or the other. It doesn't matter. If there is no separation in our humanity and in our existential experiences of grief, love, loss, joy, gratitude, then, you know, the separateness between you and I is only superficial. So presence with ourselves and others, responsiveness to ourselves. What am I feeling right now? What do I need? How can I be with the other person when I am really in touch with myself and responding to what I need? I think that's a really good question I often ask myself. And acknowledgement of our limitations, particularly. I only have 60% of what I've got, but that's what I can give. Never to think that you have to be 100 all the time. An acknowledgement of what the other person's going through. You know, particularly if I think hospitals, what brings to mind is, you know, when I was doing my hospital visit, you know, just to meet some people as part of my PhD, I sort of, you know, you can probably tell from the stories that I've told you that I have a bit of an imagination. And so I pretended, I don't know if it's okay to be 48 and pretend, but I did. I pretended that I was maybe a sick person visiting the hospital. And how daunting it was, those big, bright, white corridors. And I didn't know where I was going to go and who I needed to see and what signs I needed to look out for. And I wasn't even sick. I was just pretending. So I cannot imagine what it must be like for people who really need those services. And the only difference that told me who was sick and who wasn't just their outfits or their lanyards. It was the fact that groups of people who walk and talk, and it was the expressions on their faces and the kind of vulnerability, or in people are patients or their families, as opposed to staff were walking around they walk at a much faster pace. They were talking to each other about what they were going to have for lunch, and that really demarcated the separation. So I invite us to think about, how can we, there'll always be a gap, of course. It would be disrespectful to say I understand what it's like to be dying, because I am, but not. As far as I know, cancer of a probability is not as high as for me as someone who's been diagnosed with it. But there you go. How do we acknowledge another person's suffering and their vulnerability in a way that is respectful? I think that's key. And curiosity towards how they're experiencing. Even for patients and families, they have good days, they have shit days, excuse my language, oops. And what that day's like for them. How are they doing today? And just being with that, rather than just assuming they're just sick, or they're just the carer. How's the carer doing today? We know carer burden's high, right? And to observe the tensions of existence within ourselves, how when we talk about helpfulness, there's a really useful idea of reaction formation. So as a result of maybe just that niggling existential truth that we're all dying, niggling in the backs of our mind, we mitigate that helplessness by being extra helpful, by offering solutions all the time, by telling people what they should be doing. That's when we're not honoring our own tension of existence, and therefore really unable to be in touch with another person's. And then there's your own personal integrity, your own creative approach. How are you, every moment when you hear about, for example, when you hear about compassionate attitude, the compassion you feel right now probably is different from the compassion you felt yesterday, depending on how they're being. So if you're really being with that person and how they are, the need and that experience of compassion and sharing is unique in that moment. I think those are the ways that I would invite you to think about enlivening your own practice. How would you enliven your practice, whatever you're doing in your life, as a profession, as in your personal life? And also it's not just about being how wonderful and how practiced you are. What are some of those limitations? What are you suffering? What do you struggle with? What do you need mostly? So I think I'll leave it there, and I hope that this invites you to, in whatever ways that you do, set up a contemplative practice for yourself to get in touch with that stillness and openness in order to be with another person. Yeah, so thank you. That's the end of my presentation.
Thank you so much, Maureen. Oh, you've thrown up so many amazing ideas. I've got lots of things whirring around in my brain. I really liked your word exercise, and I found my own quite meaningful, actually. And I feel at the end of listening to this, I feel somewhat, I feel more hopeful. I feel like we're already doing a lot of really progressive things in the psycho-oncology field, and getting together in ways like this, and there are lots of other ways we can get together as well. It's a really wonderful thing to do, to connect and see that we're not alone in this journey of the personal and professional evolution that we're all going through. And yeah, so I'm really grateful to our speakers. Thank you so much, Anne. Thank you so much, Maureen. I am just going to open the Q&A box and see if there are questions. We've got a couple of minutes up our sleeve if there are. There's only my little test one in the Q&A box, and in the chat box we've got some lovely feedback. So thank you so much for your comments, everyone. Yes. There is a question there from Moira. I think it might be directed to Anne regarding resources, as in, are there resources for such supports? I think that the two of you can chat offline about that, because I don't know how to do it on a webinar, quite honestly. You'd have to just type to each other.
Yeah, I'm trying to. Sorry, yeah, stop sharing. Okay, sorry about that.
That's okay, Maureen, no problem. So thank you again. There will be a recording for everyone that registered. And I'm just seeing the last couple of comments coming through. But essentially, thank you so much for joining us. We hope to do more of this sort of thing in the future and really work together as a collective of professionals who really care about people with cancer and want to do amazing work in this space for the long term. Thanks so much for joining me and all of us. And yeah, we'll be in touch. Thank you. Good night.